Hey everyone, I'm Lisa Jordan, and welcome to MenoPositive.
I got a good feeling.
Where we take a refreshingly positive approach to navigating menopause. If you're looking for practical tips, expert advice, and honest conversations, think of this as your personal pick and mix for how to optimize your body. Although we can't prevent menopause, we can redefine it. And that journey starts now. I want to talk about something most of us would rather avoid: difficult conversations. Whether it's confronting a friend about something that's been bothering you, discussing health concerns, or even standing up for yourself at work, these moments can make us really uncomfortable, like heart racing, sweaty palms uncomfortable. Hands up if you've rehearsed a conversation in your head over and over again, imagining every possible outcome. I usually have my best arguments in my head. We then tell ourselves, well, maybe I should just let it go. Maybe it's not a big deal. Maybe I'll just shut that person out of my life or avoid them because that's easier than telling them how I really feel. The problem with that is avoiding the conversation doesn't make the issue disappear. It just allows it to fester. It creates this unspoken tension and likely misunderstandings. According to science, people avoid difficult conversations because they make us vulnerable. They expose our fears, disappointments, our expectations. Think about it. You have to be honest, not just with the other person, but with yourself. Difficult conversations don't destroy relationships. They strengthen them. They bring clarity where there was assumption. They create understanding where there was confusion or resentment. This actually happened to me recently with a really good friend who I love a lot. She was really angry with me, like really angry with me. In fact, I think she told everyone she was except me. But deep down, we both knew that our relationship was bigger than that moment, that you can both love and be angry with someone at the same time. And the difficult conversation we had was actually a real investment in our relationship, not the end of it. So today, I'm confronting a difficult conversation. This was hard for me to research. So many of us have been touched by cancer or fear it. I didn't know where to start. I didn't know how to word my questions. I'm going to be honest, it made me really uncomfortable. But then two things happened. One was, I thought, if I feel this way, I bet a lot of other people feel this way. And if I want to be proactive with my wellness, then let's hit this head on. And two, I met Dr. Fiona McCarthy. Fiona is a consultant medical oncologist and a leading authority in cancer therapy's effects on the skin. She has 2 decades of medical experience, and in addition to her extensive clinical qualifications, she also maintains an academic interest, as she doesn't spend her weekends watching Netflix, because in 2017, she was awarded a PhD for her work on the links between inflammation and cancer. And she is passionate about dispelling myths and educating women on the proactive steps we can take to minimize our risk. Dr. Fiona McCarthy, welcome to MenoPositive.
Thank you for having me, Lisa. What a lovely introduction.
Oh, it's so nice to have you here. I have the $1 million question.
Yes, go on.
Can we prevent or minimize our risk of cancer?
Simple answer, yes. So we know that, according to the World Health Organization, about 40% of cancers are actually preventable. That's a huge number. Now, I always say when I start talking about preventable causes of cancer, I always caveat it with anyone who's listening who's going through cancer treatment or has gone through cancer treatment. This isn't a blame game. I know so many of my patients will say, oh gosh, what if maybe I did this and that's caused my cancer? And as oncologists, we know it's never one thing. And we will never be able to single out exactly what has caused your cancer. But the tips that I'm going to give are just simple things that can kind of basically stack the cards in your favor.
And that's what I like. I think this idea that, I think in the UK, I saw like 1 in 2 people will get cancer. But with some of these really simple changes that you're going to talk about today,
Yeah.
they're not only helpful for preventing cancer, but they're really helpful to minimize menopause symptoms. They're helpful for
Absolutely.
overall longevity. It's like, it's not just a 2 for 1, it's a 3 for 1.
Or a 10 for one.
It's 10 for 1.
It's amazing because all of these things are really simple, but they affect every other part of your life as well. And as you said, they also help with menopause symptoms.
And you said this is one of the main questions that your friends are asking you, like at dinner parties.
Yeah.
Is this what people pull you aside and are
People
like, Fiona?
Can I just A, show you this rash or this lump or something? And B, does it really work if you really stop drinking? Does it really improve your risk of getting cancer? And I think, or when people are pouring an extra glass of wine or maybe going out for a cigarette, they always look at me really sheepishly. And I'm like, I'm not judging, I promise. But it's just like those questions that people want to ask, but kind of don't know where to start really.
So today I want to, I think we're going to just touch the surface of a lot of this, but can we unpack 2 things? I thought, one, future-proofing our health and cancer prevention. And then let's also talk about cancer and the menopause
Yes, very
transition.
important. Yeah.
For those women who may have entered early menopause as a result of treatment, or those that maybe were going through menopause and then got a cancer diagnosis and maybe they had to go off their HRT. That is a whole other show.
And also there are women that often aren't part of the menopause discussion that we see in the media and can feel very unheard. So I think we really need to address that.
Are there specific cancers that women in perimenopause, menopause, this is kind of midlife, isn't it? Are there specific cancers that we should be really mindful of?
I think, essentially cancer is a disease of aging. As we age, you are more at risk of getting cancer. So I think 70% of the cancers, or 80% in the UK, are diagnosed over the age of 70. So it's not just midlife, it's ongoing. We are all going to be more at increased risk of getting cancer. That's because the kind of changes in our DNA or the mutations build up. And usually when you're younger, your cells are in good nick and they can repair these mutations. But these mutations over time accumulate and can, in some cases, cause cancer.
I was just at my osteopath the other day about something with my neck. And I was like, was it just because of that, one thing I was doing, that when I went rollerblading that one time? And he said, this is an accumulation
Absolutely.
of your lifestyle over years.
Years and years. And we never know that one thing that is going to tip the balance into affecting the mutations for them to then cause cancer.
But there are some things that can tip the balance in our favor.
Absolutely.
As well.
Yeah.
So what are some of the lifestyle factors that would, I guess, influence our cancer risk that we should be aware of first?
Okay. So the first thing that I say is reduce alcohol or avoid it. And that's never a very easy thing to hear because, at the end of a hard day, lots of us like a glass of wine or, have a beer. But I think, like with anything in oncology or actually all health, knowledge is power. And once you know the risks, then you can make your own decisions. So with alcohol, we know the US Surgeon General came out in January of this year and said, alcohol is a huge carcinogen and really increases your risk of having cancer. And that is sadly true. And the more you drink, the more likely you are to develop a cancer-related, the more you drink, it increases your risk. Now, we know that alcohol increases the risk of at least 7 different types of cancer.
7 different types?
Yeah, at least. And then is implicated indirectly in others. So by the guidelines are there as guidelines. Ideally, in a perfect world, you would not drink, okay? But we know that's not reasonable and people have to have quality of life and enjoy it. So I say to patients, if you can avoid alcohol, wonderful. But if you can cut down, wonderful. Even if it's a case of just thinking, do I actually really need that extra glass of wine? It's simple things like that, rather than being too didactic and going hardcore and saying, absolutely stop.
Is there an acceptable amount? Like, is it 1 or 2 glasses a week or?
Essentially, no. Avoiding alcohol, it should be the
goal?
Should be the goal. But if once you drink within acceptable limits, the UK guidance is, I think the problem with the UK guidance, and actually all guidance, is none of us know the measures we're drinking. I think what I think is a glass of wine and what you think of a glass of wine is very different potentially. So I think it's just being very aware of how much you are drinking and to make sure that you're within safe limits. Safe limits being, however much you're allowed to drink in the UK a week. I think it's 14 units for a woman. But in terms of cancer risk, if you really want to be stern with it, it has to be no alcohol.
Okay, so we have alcohol. I'm assuming smoking is the next thing.
Smoking, and actually I say vaping as well. I have to say the evidence isn't there as yet in terms of vaping with the cancer risk, but I think we are probably 10 years, behind, and we'll be having a different conversation in 10 years. So for me, smoking and vaping come as one. The other thing is physical activity. We know that, and actually before that really, is obesity. Obesity, in 2021, they thought that obesity caused about 10% of the cancers in the US. I mean, that is a huge, huge amount. And also, it's a very difficult conversation to have because obesity can be multifactorial. But we know that maintaining a healthy body weight and a healthy BMI reduces your risk of, at least 10 different cancers. And then that feeds into physical activity. Again, physical activity can reduce the risk of colorectal cancer, for example. And there's accumulating evidence to show that it will probably reduce your risk of other cancers as well. So they are all feeding into each other. Simple lifestyle things that you do have power over and you can control, but that we kind of almost put our heads in the sand about a lot of the time.
Yeah. No, and I want to rephrase it actually, because I think another way to talk about it is really, what are the things we should be doing more of?
Yeah. And I think we have to look at it as really positive steps. We've gotten to this point in our lives. We want to make sure that the rest of the lives we have are lived in the best possible way and they're not impacted in any way by disease or illness. So we want to put these positive steps in place now. And it doesn't matter what age you are, you can put them in. It doesn't matter if you're 70 or 30, we can put them in and make a positive impact on our health. So I'm really keen to make it this whole kind of framing of lifestyle modifications a really positive one. The other thing that we can do as well is making sure we wear our SPF and avoid excess sun and UV radiation, because that's a really big thing.
Okay, I want to talk about this for 1 second.
Yeah.
So vitamin D.
Yes.
It's, going out in the sun. It's good for you, but don't get too much. Like wear your SPF, but the SPF doesn't let the vitamin D in. I mean, what is an acceptable amount of sun exposure?
So I would say that there have been studies that showed that even wearing SPF 50 all day long doesn't affect your vitamin D absorption.
Okay, good news.
But I would say you just do not roast your skin. You do not go out without your SPF. It doesn't have to be SPF 50 all year round. It can be SPF 30 and above. But you do have to wear SPF to protect your skin against melanoma, squamous cell carcinoma, basal cell carcinomas, 3 of the big skin cancers that at some point lots of us will get, because basal cell and squamous cell, or particularly basal cell, happens when you're older. And we often will develop them as we age anyway.
And let's look after our hands as well, right?
Yeah.
Because we're putting it on our face, like if we're going out during the day and we have our clothes on, but I think we forget about our hands. That's
and
important
necks
too, right?
as well. I think that's another place that we forget about as well. So it's not just your face, neck, anything that is sun exposed, I would just pop a bit of SPF on. It's such a simple thing to do, but loads of us forget about it all the time. But it's a really simple intervention.
I always think it's actually, with all the young kids getting into skincare, it's the one thing I'm trying to tell my daughter to put into her skincare routine.
Absolutely. And if the same thing with my daughter, if there's one thing she can do for herself, for her skin, for her health and everything, start now. But actually, that generation are so much better than us. They're so much savvier than us.
Now, you mentioned exercise.
Yeah.
What are we talking about here if we can add more exercise into our life?
So I think again, small steps. When the cancer studies talk about, or the cancer prevention studies talk about exercise, they're not talking about going to the gym for, I think the guidelines are ideally moderate exercise for 150 to 300 minutes a week, or intense exercise for 60 to 70. We're talking about lifting bags of shopping, walking up the stairs. These are not, you don't have to be in the gym for 3 hours a week.
Gardening,
walking around, just, your normal life. But once you don't live a sedentary life, once you're not sat on the sofa eating processed foods all day, it's simple things.
You talk about processed foods.
Indeed.
Oh, danger.
Danger, indeed. Well, we know that with red meat, for example, that does increase your risk of, say, for example, bowel cancer. And we know that there's increasing evidence that processed foods also increase your risk of other cancers. Again, accumulating evidence. And again, with food, with things with diet, it's multifactorial, because if you're not exercising, you're less likely. If you're not having a good diet, you're more likely to put on weight. So then, is it the weight causing predisposing you to cancer, or is it the lack of exercise and the rubbish food? It's a very difficult one to pick apart. But we know, basically, move more, eat well, simple as.
Okay, so let's go through again, like, what are some of the things we can do to reduce our chances? Exercise.
So reduce alcohol, don't smoke or vape, exercise regularly, maintain a healthy weight, and also wear SPF. And the really important thing is about screening. Go to your screening appointments.
Okay, I'm excited about this part. And anybody who's listening should tune in now, because which screenings, what should we be screening? How often should we be screening? Give us the lowdown on this, and what we should put on our to-do list.
Okay, so really important. And again, at this point, I heard a quote last week about women in their midlife, about that we're all trying to hold up the sky with trying to do everything on our list to do.
Yes, we're seeing all the memes, right? Yeah, exactly.
I love it. But we are really bad at prioritizing ourselves and our health. And this is the best gift we can give to ourselves. So go to your smear appointments every 3 years. From the ages of 25 to 64 in the UK, you will get an invitation for a smear if you have a cervix. Go to your smear appointment. Mammograms, screening starts at 50, so you will get an appointment kind of maybe between 2 to 3 years on your 50th birthday. So anywhere between 50 and 53, go to your mammograms again. And bowel cancer screening has changed recently in the UK. So from 50 onwards, every 2 years, you will get something through the post called a fit test, and that you give a sample of your stool, it's sent off, and then they check whether you need to have a colonoscopy, whether there's any blood in that sample, and whether you need to go and have a colonoscopy for further investigation. So those are the 3 things in the UK at the moment that are free, that are on the NHS, and that will, smears will reduce your risk of getting cervical cancer, and it's proven. Same with mammograms and your fit test. Again, detect cancer early.
I want to talk about the length of time between some of these. So I find it, so I'm from Canada, and I actually don't even know how that may have changed. But when I was younger, you had a smear test like every year.
Yeah.
And even this idea of mammograms only starting when you're 50.
Yeah.
I know you are really big on preventative medicine. Is there any view or any discussions that are happening about moving some of these tests earlier, like earlier into your 40s?
So for smears, for example, it starts at 25, and there was very sadly the death of a very well-known woman in the UK about maybe 10 or 15 years ago, in her early 20s, and she changed a lot of people's view on whether you should be getting smears at an earlier point. And actually the answer is no, because we know that cervical cells in your early 20s, for example, can show lots of changes that will settle down on their own. And actually you are more likely to cause problems by having smears earlier and having unnecessary treatment than starting at 25. So that's why the law hasn't been changed on that. And that's why the guidelines are 25 with smears. With mammograms, it's slightly different. In the US, it was 50. It went down to it was 40, went up to 50, went back down to 40 again. I think at the moment in the UK, it's 50 to 70. The reason for that is often women in their 40s may have denser breasts, and you may get a lot of false positives with the mammogram that people end up having further investigations that are unnecessary. So there is a reason behind the 50. It's not just a cost-saving exercise, which I think a lot of people think it is.
Yeah. I mean, shout out to my friend Jay, who was on me to get my mammogram. I was late in getting mine, and he had a I guess, a personal experience with it. And he was that friend who was like, Lisa, like messaging me all the time. When are you going to get it? When you get it? Have you booked it? Have you booked it? Have
I
you booked
love
it?
that he did that, though. How amazing.
It was amazing. I literally, I was in the room. You know, you go in a little room before you go in for your screening when you get your gown. I literally took a picture
and sent it to
in the
him.
room, and I sent it to him. And I said, look where I am. But I mean, really shout out to friends like that who are really encouraging you to go out there and get your screenings.
And also, it is scary. Like, even as an oncologist, I go to these things and I'm like, oh my gosh, I hope they don't find it. You know, it takes guts to go, because we all know it's really easy to go, oh, you know what? Oh, maybe I'll just push it back a couple of weeks, and then something else happens. But actually, we know early diagnosis saves lives. It's really straightforward.
And that's what I was talking about in the opening conversation, was difficult conversations. Sometimes not knowing, people don't go because not knowing feels safer.
Yeah, absolutely.
But actually, it's better to go, get the screening, and whatever it may be, then you can address it. And like you said, if you catch things early enough, then a lot of these things are treatable.
Absolutely. And we know better outcomes come with early diagnosis, particularly in breast cancer. So it's super important to not put it off, which is often the easier thing to do, and it's the less difficult thing to do.
So for anybody listening, I want you to message a friend, your mom, your sister, just check in when they've had their last smear, when they've had their last mammogram. I mean, there should be parties. I think it should be like doctor's visits to the home if they could.
And but also just even say, like, I love that idea of just messaging a friend and say, right, come on, we can do this together. Let's go and book it. You know, we'll hold each other's hands. We'll just be there for each other, because it is sometimes that emotional support you need, and it is hard. You know, you talk about difficult conversations. These are difficult. You know?
But you're so grateful when you get the news that everything's okay. And like I said, I think the main message is, if you do have something that looks a little bit dodgy, then you can address it right away and get the help you need, because it can be
Don't
treated.
put your head in the sand. It's, again, if there is something that you're worried about, even if it's a niggle in the back of your mind and you're trying to ignore it, you know your own body. You know, believe in your own intuition. Go and get it sorted.
Are there some signs that we should look out for as well, that things may be off?
You mean with breast cancer?
I guess that's I guess, there is no general cancer question there, is there?
Well, I think with cancer, I think a lot of it is you just don't feel quite right. Sometimes our patients will say, well, you know, when they've had their treatment, how will I know if it's coming back or anything? And a lot of the time we'll say, yes, there are things like, you know, you may lose more weight than you're expecting, or you may lose your appetite, very generic things. You may feel more tired, but sometimes you just don't feel quite right and you can't put your finger on it. And I think that's, again, why I say about trusting your intuition. You know, sometimes there isn't a one concrete thing. It may be just a feeling. But I think that's when you go. I think with breast cancer, yes, there are definitely signs. Like, obviously, we all know about having a lump, and, you know, you need to examine yourself at the same time every month. But things like, you know, maybe you might get some nipple discharge, and sometimes it isn't a lump. It's kind of some puckering of the skin, or some colour changes on the breast, or your nipple may be slightly more inverted than usual. So all of these things are subtle signs, but they are a sign that there could be something wrong. So again, most of the time, there'll be a sign of nothing being wrong. But you don't want to miss out on the chance of early detection.
And I think we are our best doctors.
Yeah.
If we're not feeling right, then we're not feeling right. And I think that conversation is even changing with our GPs and other specialists about, okay, well, let's investigate this further than being put off.
Yeah, and I think you have to, in this day and age, advocate for yourself. Which isn't easy when you've gone to if you've gone to your doctor and they've said, oh, don't worry, there's nothing wrong. But if you feel strongly enough that there is, you need to go back and speak to them again. I think you have to be your own advocate.
And what about genetics and family history? Does any of that play a role in?
Absolutely. It plays a role in lots of different cancers. But the genetic element is actually far smaller than you would expect. Even in the instance of breast cancer, it's probably in the order of probably 5 to 10% maximum, probably 5%. So it's actually the genetic component of cancers is much smaller, but it's something, again, that we all hear about. And if you do have a strong family history of cancer, you can go to your GP and they can refer you to a clinic where they will assess your family risk and see whether you do need genetic testing.
And is this a myth? Like, is this true or is this fake news? I remember hearing once that, especially on a breast cancer, that, you know, if your grandmother had it and then your mother had it, then you'll have it, or it skips a generation.
No, I mean, Again, if you have one person in the family and your first degree relatives, so like mother, sister, have breast cancer, you are more likely to develop breast cancer. But that's not saying that it's a genetic component. It can just be environmental factors. We don't know. A true genetic component where you have have a mutation that is passed down through the generations is still in a very small percentage. But if you do have that very strong family history and you're worried, it is worth going to speak to your GP, because you can go to a family history clinic and have a true genetic assessment done, even in terms of the history. Because actually, for clinical geneticists in the family history clinic, or for a clinician doing the family history clinic, they can pick apart quite easily, because it's not just female cancers that can predispose you to having other cancers. Say for the BRCA genes, you may be more likely to have prostate cancer if there's men in your family. So you need to pull apart not just the female members of your family. It needs to be a full view on all of members.
And you were talking about nutrition. We touched on that a little bit. I'm really fascinated in gut health.
Yes, the microbiome. Yeah.
So what kind of things can we be eating that would also help us prepare our bodies to fight off cancer or prevent a cancer risk?
I think with diet, it's very important to be sensible. Lots of fiber, limited processed foods, or if any, avoid sugar-sweetened drinks if you can as well. And lots of fresh fruit and veg. They say 3/4 of your plate needs to be fruit, veg, pulses, grains, and fiber, and then you have your protein for your quarter. I think that's a kind of sensible approach. We don't talk about it enough as doctors, because we're not necessarily educated about it at medical school. But I think you have to be you have to enjoy life. You have to have quality of life, but also quality of life comes with health. And we know that nutrition has a huge impact on your health.
Let's talk about inflammation as well, because I know you did a PhD in this. Like I said, you don't spend your weekends watching Netflix, do you, Fiona?
Oh, I don't know about that, Lisa.
What are you watching right now?
Oh my God, we'll talk about it later.
Okay, we'll talk about it later. Again, inflammation is good. When you have a cut, it's really good for you, but inflammation is bad.
So there's a difference between acute and chronic inflammation. So acute inflammation is good. So we have, as you said, a cut, our inflammatory cells that our body produces flock to that area and help it to heal. But we know in sites of chronic inflammation, you are more likely to get inflammatory cells that can mutate and can become more cancer-promoting cells. And you can we know that tumours can develop, and this is not new. This has been going up back since the 1800s, actually. We know that tumours can develop in sites of chronic inflammation. So things like, for example, hepatitis. We know if you have chronic hepatitis, you are more at risk of developing liver cancer. So it's things like this. We know that chronic inflammation can predispose you to cancer.
Overall, for inflammation as well, I think it's still, eat a healthy diet, exercise.
With all of these things, inflammation is implicated in so many diseases these days. It's coming to the fore as a driver of many diseases. And I think, again, it's just trying to modify those lifestyle changes. And again, it's the same for all inflammation. Reduce alcohol, reduce smoking, or stop smoking.
We're going to hear that a few times on this episode, I
might,
feel.
yeah, you might be very bored of that. But if one person can take away from this, going, actually, I might cut down my booze, or I might stop smoking,
you will have done your job.
Yeah, my job is done.
You will have done your job. Let's talk about hormone replacement therapy.
Yes.
So many myths, so much confusing information.
Absolutely.
I think it's a personal choice.
Yep.
And as long as you're informed, then you can make an informed choice about it. But there is still, I come from the Women's Health Initiative. My mom was part of that generation.
Yep.
That baggage has been passed on to me. Obviously, I'm learning so much more about it now that I'm able to change that view or narrative.
Yeah.
But what can you tell us about the risks of HRT and cancer from an oncologist's perspective?
I think you're right. The Women's Health Initiative back in the early 2000s did a huge amount of damage in terms of the perception of HRT. And I think, that generation of women, say our mum's generation, were on HRT and then had to stop because there was all this. And I think I read somewhere that, 2 million women at that point were on HRT, and it dropped down to 1 million within 2 years, or less than 1 million, which is a staggering fact, particularly when you consider the health benefits of HRT that we now know. Now, since the last few years, there has been more review of those studies. There's been a review published in 2019, about 58 different studies. And actually, we know that HRT does increase your risk of having breast cancer, for example. But we know that risk is much smaller than originally thought. So yes, it does increase your risk, but it's a small increase in your risk. So I think from an oncologist point of view, again, informed choice is very important. It wouldn't be something that I'd say you don't have. I think it's a very much an individual decision. It's different if somebody has a personal history of breast cancer or endometrial cancer. That's a different discussion. But for the general population who are at low risk of having breast cancer, again, informed choice about the pros and cons of HRT is really important.
What are some of the non-hormonal options for HRT? Is that something you can, when all
Yeah.
your work with cancer patients?
Yeah.
I'd love to hear what, in your experience in working with women, what are you seeing are some of the most common non-hormonal treatments?
So I think the first important thing to say is there are options other than HRT. And I know with the advent of social media that really, and during the pandemic, that there was this kind of influx of knowledge about HRT, and it seemed to be the cure of all ills. But we know that lots of women can't take HRT for a variety of reasons, or actually don't want to. And from our point of view as oncologists, if somebody's had breast cancer, generally we would say we would prefer patients not to be on it. But it's not enough for us to say we don't want you to be on it. We have to offer options. And I think there's a really big non-pharmacological and pharmacological options for patients in this situation. The non-pharmacological ones can be incredibly effective, particularly for things like hot flushes. So things like cognitive behavioral therapy can actually have a huge impact on the hot flushes. Paced respiration, a breathing technique, can be really helpful. Acupuncture can be helpful, auricular acupuncture. The evidence, there's a few trials that show it does show some benefit in hot flushes. So things like that, and actually regular exercise, all of those things can really help with some of the effects of early menopause brought on by either your cancer treatment or if you're going through menopause after you've had breast cancer and you're not able to use HRT. And also there are some pharmacological interventions that aren't HRT as well. There are drugs that are available to help with hot flushes that don't promote estrogen in any way.
Is there any new research or science that you are really excited about when it comes to cancer prevention?
I think I have to say the thing that I was really excited about this year, and as oncologists we'd probably get excited, but nobody else would, is the Surgeon General coming out and saying alcohol is a carcinogen. We've known it for years. It's a very difficult conversation to have with patients, and actually a difficult conversation to have with friends. I mean, and ourselves. And we all enjoy a glass of wine. You don't want to be the killjoy at a party, but I think it's really important for people to know this. It's a bit like having the knowledge that smoking causes cancer and not sharing it with anyone. And I think that for me is actually sadly very exciting that there has been this focus in the media that alcohol does increase your risk of getting cancer.
And like we said, you can then make an informed choice.
Absolutely.
And you still have to, if that's something you enjoy, then you can moderate.
You can moderate appropriately, and you may just not drink as regularly, or you may drink slightly less, or you may decide to cut it out completely. But then you can make an informed choice. It's the same with your kind of with the idea of obesity. And I know there's, it's not fat shaming somebody. It's just giving them the information, because again, we would be remiss to know that the increase that it can cause in your cancer risk and not tell people.
We talk a lot about lifestyle changes to support you during the perimenopause and menopause transition. And I think a lot of these lifestyle changes that you're suggesting, like I said,
they can help every day.
They help everybody. They're just great life lessons. And if this wasn't, if menopause wasn't reason enough, then here's another great reason for you to start, maybe make one change today.
Yeah. You don't have to reinvent yourself. I mean, you just take up the invitation for screening. Cut down your alcohol intake. If you're vaping, try not to. It's little things. You don't have to become a whole new person and live a pure life, but you do have to just know that these things stacked up can improve your risk of developing cancer.
Yeah, and go get your screening done.
Go get your screening.
Go get your screening done. Okay, I want to acknowledge that the cancer community is sometimes omitted from the menopause conversation. And just like there's no one size fits all for menopause, there's no one size, fits all for cancer as well. And I mean, as I was preparing for the show, I find it's so difficult to believe or to understand that life-saving cancer treatment you had has now put you into early menopause or has forced you to go off your hormone replacement therapy. Yeah. Can you explain the different situations that women find themselves in when they're faced with a cancer diagnosis at the same time as perimenopause and menopause?
I think there are a few situations. Sometimes we will see patients, say, for example, with breast cancer being the easiest one for particularly at this age group, for lots of people are very aware of it. So often we'll have patients, if they're under 40 and being diagnosed with breast cancer, we know that the chemotherapy that we give them can induce early menopause. And often we will, even after their chemotherapy, we will suppress their ovarian function in women with an estrogen-sensitive cancer to reduce the risk of recurrence. So you're really flattening your estrogen, to a deadline. So the symptoms with that are really severe menopause. And actually treatment-induced menopause the symptoms can be much more severe than a natural menopause. And we know in under 40s, as I was saying, that, about 40% of people will go into an early menopause and stay in an early menopause. Over 40, if you're diagnosed, for example, and you have chemotherapy to reduce the cancer coming back or to shrink the cancer, we know that 70 to 80% of people will go into menopause and they won't get their periods back.
And is this because the treatment can't specifically target the cancer, or?
We know that twofold. We know that the chemotherapy, for example, can be toxic to the ovaries, but we also know that to reduce your risk of the cancer coming back, we often do ovarian suppression therapy. So we quieten the ovaries down for a period of time after your chemotherapy to ensure that there is no estrogen going through your body from your ovaries.
And can that be reversed for some women as well? Like when you suppress it, can it eventually come back for some?
So as I was saying, with under 40, we know that about 40% of people will never get their ovarian function back and they will go into menopause. If you're over 40 and diagnosed, you're much more likely, 70 to 80% will actually be into menopause, and that's it.
And is that also medical menopause, or is that different?
So that's medical-induced menopause.
That is okay. I just want to get the terminology right.
So that's medical menopause. So that's or medically induced or treatment-induced menopause. You can also have surgical menopause when you have your ovaries out for example, for ovarian cancer or for gynae cancers or for, say, for example, lymphoma. So I'm also very mindful to think that it's not just about breast cancer and HRT and breast cancer and menopause. There are lots of other cancers that can put you into an early menopause because of chemotherapy.
So what is your advice to women as they're navigating that?
I think, first of all, if you've gone into early menopause, first of all, actually, as oncologists, we need to be better at explaining what the symptoms are with our chemotherapy, because we're so fast to jump on a diagnosis and make sure people are going through treatment for the best intentions. But I think we also need to be telling them what these symptoms can be. We talk about, yes, your periods may stop, but we don't necessarily talk about the extreme hot flushes or the vaginal dryness or the absolutely, exhausting tiredness that a combination of early menopause and chemotherapy can cause.
I can only imagine.
It just boggles the mind. So I think we need to be really good at talking to people up front, because again, knowledge is power, and front loading them with that information is actually very helpful. And we can't fix everything, but at least if patients know what to expect, they're not just given this double whammy of cancer diagnosis, treatment, and then all of a sudden the menopause coming from nowhere. Yeah. And I think it's really important to talk to your oncologist as a patient about your symptoms or your clinical nurse specialist, because there are things we can do. It's not just, say, for example, again, I go back to breast cancer or gynae cancers with, we know that HRT is not what we would want our patients to be on, but there are other non-medical things, like the lifestyle things we talked about, but there are also some, pharmacological interventions that we can prescribe to give, to reduce your risk, reduce your hot flushes, for example, which can be really distressing for people.
Is there anything there that you're really excited about or that you're seeing is working well for some patients?
So we've had medications for quite a long time to reduce hot flushes. They're not always been the most effective. There is a new medication that has been licensed in the last year for hot flushes, and it reduces it down by, I think, up to 60%. So it's quite significant.
So there is help out there. There is
Yeah.
support out there. I can only imagine, understanding what is a symptom of menopause, what's just a symptom of my treatment, and how that can be so confusing.
And absolutely. Fatigue, of course. You can be exhausted from your cancer, your diagnosis, your cancer treatment, and your menopause, and also the psychological impact. I mean, it's so intertwined, the kind of menopausal symptoms and your cancer symptoms and then your chemotherapy. It's really hard to pick apart. But I think that's why it's really important to have a good relationship with your oncologist and your clinical nurse specialist and talk about your menopausal symptoms, because we don't know what we don't know. And a lot of our patients will say, oh, but I'm just lucky to be having my cancer treated. I shouldn't be complaining. You should. This can be really grim, and we can do stuff to help.
And I think educating people on and giving them permission to have that conversation.
Absolutely.
Because again, like you said, you're grateful that you're having treatment, but you don't need to suffer, is what I'm hearing you say.
And suffer, you don't need to suffer in silence. And yes, as oncologists, we can't fix everything. But there are lots of things that we can do to improve somebody's quality of life. And it's a two-way thing. We need to be better at educating our patients about the symptoms that they may experience. And patients need to talk to us about what they're experiencing. If one of my patients was suffering and not telling me, I would be so devastated, because there is stuff that we can do.
In addition to the, you said there's some pharmacological support. Again, if anybody's listening and they have a friend or family member going through this, or they're going through this right now, is there anything other than going back into their doctor and their oncologist and having this conversation, which we want to empower and advocate everybody to do, but is there anything that they could do today that could help them, advice you'd give them?
For example, if you're having the fatigue from, again, it's hard to pick apart whether it's your cancer treatment or your menopause, for if you're going through, for example, cancer treatment, and you've gone into an early menopause, things like regular exercise can really help. And it's not what you want to do, and when you're exhausted you don't want to do that, but we know that physical activity can improve your menopause symptoms, can also reduce your risk of cancer recurrence. It's so multifactorial, so it's, again, not very exciting. It's not a magic tablet, but it's really simple things like that. And that's why I think it's really important for patients to come and talk to us, because there are, again, lifestyle things that we can say, actually, this is really helpful, that patients don't necessarily know.
What I also like about this, though, is as I'm sitting here listening to you, if you are the friend or the loved one or the family member of somebody who is experiencing this right now, you can go have this conversation with someone too, right?
Yeah.
And you can say, how can I best help this person?
Yeah.
Because if it's like, come on, encouraging them to come out, let's go for a walk, or here, I've made this healthy meal for you, or whatever that may be, then there's advice for those people to better support.
Yeah, and there's a brilliant website as well that I often tell people to go to, called Menopause and Cancer, run by somebody called Danny Binnington, who is
Great website.
Oh, she's so inspirational.
Yes.
And I think that has such sensible evidence-based advice, but also really practical advice. So if you are going through cancer treatment and you're in an early menopause, or if you're one of your friends or family, I think it's a really good website to signpost people to.
She has a great podcast as well.
Amazing podcast.
I listened to a number of the episodes, even just to prepare for this show.
Yeah.
But Menopause and Cancer, Danny Bennington doing some great work. And I feel very relatable.
Yeah. It's very practical, sensible advice that you'd want yourself, or you want to give to your friends.
Do you think there is an argument to have more of a holistic approach to managing cancer and menopause, like bringing different people together to help the patient?
Absolutely. I think whether it's the team approach from the patient, bringing in people with them to advocate for them when they're feeling maybe not as strong in themselves, or from the medical side, having a group of professionals who are with different specialties, with a different hat on, who can kind of look at it in a different way. So the hospital that I work at has a gynecologist who has an interest in menopause and cancer. And, for difficult conversations, or if people do think, well, actually, I know I've had breast cancer, my symptoms of menopause are really awful, I'm thinking of starting HRT. I want to have that conversation. We send patients to the gynecologist to have further conversations, and we do it as a multidisciplinary team. It's not a single voice. We try and do it in the best way we can. And also we have clinical nurses who are really, both gynecology and breast cancer clinical nurses who are really experienced in having these conversations too. So I think best practice is always a multidisciplinary approach because it means best care for the patient.
And I love that idea that you have this team behind you that wants you to get better and wants to help you through it.
And wants you to have a good quality of life. It's not, there is, one size doesn't fit all, and we have to treat everyone individually because different things matter to everybody.
And I know you have a specialty in skin as well. And you have 3 Ps around skincare.
Yes. Well, and actually all these 3 Ps are kind of the tenets of my approach to everything in medicine. It's practical, preventative, proactive. I mean, if we could just have those 3 Ps for every part of our health, I think that would be really, really key.
Let's say that again. What are the 3 Ps?
So practical, preventative, proactive.
And we know with breast cancer as well, early detection.
Very much. Early detection saves lives.
Early detection saves lives. Are there any myths that you want to dispel?
Oh, I mean, so many. I mean, actually, I have to say, I have just finished Dr. Liz O'Riordan's book on the cancer roadmap. She has just written an incredible book. She's a breast surgeon who sadly developed breast cancer herself. And she's been through a very difficult experience. And she's a keen educator of both healthcare professionals as well as the general public about cancer. And she has written a beautiful book on just explaining what cancer is, but also going through the myths about, why you got it, why you didn't, and, what people ask her all the time. So I have to say, I couldn't say things more beautifully than Liz. I would recommend people go and read that book. It's excellent. And even for the general public, it's a fantastic book.
What's it called again?
I think it's called The Cancer Roadmap.
Cancer Roadmap. Are there 2 or 3 things that you remember from the myths?
I mean, there's a lot of our patients talk about diet and cancer, whether they should be on special diets during cancer treatment. Absolutely not. Sensible, plenty of fruit and veg, lots of fiber.
Eat the rainbow. Nothing very exciting. And I think Liz says in her book, sadly, we don't have a magic pill that can, but if any of these things like exercise, reducing your weight and making sure you're healthy weight, if these were in a pill, people would be buying them. That's the reality. Somebody would be making millions
Somebody
off that.
Somebody would be making millions, but it's not very exciting advice, but it's the reality and it's evidence-based.
And are there any new amazing therapies that we should know about or that you're excited about?
I think with the advent of immunotherapy 10 years ago or maybe more, that has changed the paradigm of cancer treatment, worldwide. And I think there is always something new and exciting on the horizon. But I think immunotherapy has been, during my career as an oncologist, has just changed our practice immeasurably.
And does that help with all cancers or just some cancers?
Not all cancers. Not all cancers are immune mediated. But yes, with actually majority of cancers now, you can use immunotherapy.
And explain what immunotherapy is.
So it's modulating the body's immune system to ensure that the cancer is. I'm trying to think the best way to describe it.
Yeah, layman's terms, Fiona.
Immunotherapy is modulating the body's own immune system to fight cancer.
That is very exciting.
Yeah.
So watch this space.
Well, it's been around for about probably more than 10 years now. But, the advances, for example, with melanoma, melanoma has essentially, even advanced melanoma has essentially become a curative disease since the advent of immunotherapy. It totally changed the treatment of melanoma and it totally changed survival in melanoma.
Well, that is great news. I think that is great news to end on almost.
Yeah.
What I wanted to ask though, so if someone wants to be truly proactive and take a proactive approach to cancer prevention, what are the most important things that you would recommend or screenings that they should ask their doctor about?
Okay. Reduce alcohol, keep a healthy weight, exercise regularly, stop smoking or vaping, wear your SPF, go to your screening. if anyone's going through cancer treatment, the Macmillan Cancer website is the one that I signpost everyone to, because I think it has evidence-based, sensible advice for patients. And it also is very holistic. So it's not just talking about the more medicated interventions. It talks about lifestyle interventions too. And I think speaking to your oncologist, it's really important to have that open dialogue.
And we've talked about lifestyle and quality of life. You mentioned this other lovely charity. Was it Future Dreams?
Future Dreams for breast cancer patients.
For breast cancer, is it?
There's an incredible charity called Future Dreams in King's Cross, but they do, they welcome anyone through their door who has gone through cancer treatment for breast cancer or going through, and they are an incredible welcoming community. And it just is I described it to somebody as a warm hug for cancer patients. And every time I leave, I have tears in my eyes, because I would want every patient in the UK to have that kind of enveloping and looking after, because they offer they have, breast care nurses there, and they have incredible support there in terms of lots of complementary therapies, but they really look after somebody holistically. So, for example, they have beautiful, after breast cancer treatment, often the bras that may be available are kind of very functional, but they have really beautiful bras so women can feel more themselves again. It's just really simple things like that can make a massive difference to patients.
And you said it at the beginning, right? Small things can make a big difference.
Yeah, small steps. Don't reinvent the wheel. Small steps, not exciting, but little things build up, and little things can change your life really well.
The final question we ask all of our guests, Fiona, is, knowing what we know now about cancer and midlife, which also includes the menopause transition, but what would you tell our 35, our 45, and our 55-year-old listener?
It's never too late to start your lifestyle changes. And if you're 55, 65, 75 even, again, lifestyle changes can reduce your risk of cancer. And that goes from our kids all the way up to your 80s, 90s.
Dr. Fiona McCarthy, thank you so much for being part of the MenoPositive community and for bringing your sunshine into the studio today.
Thank you so much for having me. It's been lovely.
If people want to find you, where can they discover you?
So I'm on Instagram under my Dr. Fiona McCarthy name, and my email is on there as well.
Wonderful. Now, not all cancers can be prevented, but today we talked about some of the steps we can take to reduce our risk. Your health is in your hands more than you think, and being proactive through lifestyle choices, screenings, and informed conversations like this one can make a real difference. If you have concerns about your cancer risk related to menopause, don't be afraid to have that difficult conversation with a loved one or your doctor. Take a deep breath, find your words, because facing the truth, whatever it may be, will always bring you more clarity, control, and peace than avoiding it ever could. Your health is worth the conversation. See you next time. Now, Fiona, I bake for all of my guests.
Oh, very exciting.
I went on the cancer research website to look for recipes that were great for prevention. Not that the food prevent, but has the right ingredients. So these are some oatmeal chocolate chip squares. They've got, great fiber-rich oatmeal in them, lots of flaxseed in them.
Yeah.
Mega fatty acids, I believe. So anyway, this is like our virtual kitchen table where all the best conversations happen. So I hope you can take them home and enjoy them.
I will indeed. Thank you so much.
Or we can break them open now.
Yeah, exactly. That sounds lovely. Thank you so much for having me, Lisa. This has been lovely.
Oh, and by the way, I knew you were menopositive when you downloaded this episode. Thank you so much for joining me today. I love bringing this information to you, and I love that you're taking control of your health. You can follow MenoPositive on Instagram, TikTok, and LinkedIn. If you haven't yet, please subscribe, rate, review, and share this podcast. Join me next week as we discover more ways to optimize our bodies. Because together, we're going to redefine menopause.
I got a good feeling.